District, and I would like us to stand as we pledge allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Public comment session. Is there anyone here today who wishes to share with us a public comment? I don't see anyone that I don't recognize. So if there's no public, we really needed this public comment session. We really needed it until we put it in our agenda. And after we put it in the agenda, rarely has it ever been used. But I see no reason why to take it out. But it is, okay? We have the consent agenda in front of us, item number 4. And there's 3 items: the approval of the May 23rd minutes and the division reports. And I'm going to stop here just briefly and let you know quite a few of the authors of the items in the division reports are not in here, but their director has assigned these out to various people. I really appreciate these. Obviously, we don't have time, nor is it a good use of our time to ask all of these people to come in and give an oral report. But probably working with Eric, beginning at our next meeting, we will have at least one person, rather than give a division report only in writing, have that person come and speak to us and give you a chance to hear details and give you a chance to ask questions of the presenter. It didn't take me long when I was reading through the division reports to find some issues I'd like to ask questions about. I'd like to know more about it. They're very interesting, and we as board members need to know really what's going on out there where the rubber meets the road. So be expecting verbal reports, 1 or 2 or so, each meeting if we have time to work it in, beginning at our next meeting. So the division reports, the contracts, you will see several contracts. One of the reasons why there are so many contracts on this particular meeting, this is the transition for the year, the beginning of a new year, and so a lot of these contracts are annual, and therefore they show up on this report. By the way, if you run some quick figures, these contracts right here amount to about $1.3 million, which is about, in rough figures, and our Chancellor of the Exchequer can correct me, but it's about 10% of our whole budget is represented in these contracts right here today.
I think it's a bit more.
See, I told you she corrected me. So that's the consent agenda. Is there anything you want pulled or any item you want further discussion before we vote on the consent agenda? If not, I would entertain a motion that we adopt and approve these items on our consent agenda. Keep in mind that the contracts have already been signed, but nonetheless, they still fall finally in our laps to approve. But they have been signed. Is there a motion?
Mr. Chairman, I make a motion that we approve the consent agenda as here presented.
Is there a second?
I'll second.
All right, thank you. We have a second. Any further discussion? If not, all in favor of adopting the consent agenda, indicate by saying aye.
Aye.
And no, so you may vote. If not, we will register a consent agenda is passed unanimously. Okay. The next item on our agenda, agenda item number 5 is the election of officers. This is an annual duty of ours to elect a chairman, a vice chair, and a trustee. And also, it used to be only trustee, but now it is also the executive council. And these are the people who take care of important items in between the annual meeting. And right now, I hold the position as chair. Glenn is the vice chair. And along with that comes the responsibility as trustee. Now, the state doesn't say exactly how we should go about this, so we have options here. You can do it in one group, or you can take them one at a time. What is your pleasure?
Mr. Chairman?
Yes.
I think that would be best if we could do it one at a time.
That's the choice. You may sure do that. So the first item up then would be the chair. Nominations are open then for chair for 1 year.
Mr. Chairman?
Yes.
If I may, I have tremendous amount of admiration for the years that you have devoted to the Panhandle Health District, and it's incredibly admirable for what you have done, and this organization have been heavily influenced by your input over the years. But we're entering a time where pandemics are becoming more frequent. And even the past head of the CDC says there's going to be pandemics on the horizon. And there's a lot of gearing up for that. And we have 3 physicians on the board now that I think that with the onslaught of what may be coming and is advertised as coming, that it might be time for perhaps Panhandle Health District to move in the direction of maybe perhaps utilizing the physician input, because we know from past experience that nationally there were recommendations made that were impacting the whole nation and didn't apply to every part of the country, and more local input and control would have been probably beneficial in retrospect. And they're now admitting that many of their recommendations didn't have the scientific basis for them at the time. And with Dr. Fletcher's presentation on frame shifting, et cetera, I would like to nominate Dr. Fletcher for the position of chairman.
All right. Dr. Fletcher has been nominated. Are there any other nominations?
Yes, I'd like to nominate Marlo Thompson.
All right. I have been nominated. Is there any other nominations? Okay, I hear no other nominations, so we will close the nominations, and I think you may have at your desk a 3x5 for our card. Okay. Did Glenn and I get?
I've got cards here.
Yeah. Okay, so we have two nominations. I would instruct you to write one name and
So would you like to have the candidates make a speech before we do that, or?
if you would like, I can make my speech really short. I've been here for a long time. And so you can decide whether you want me to carry on or not. That's my speech. Dr. Fletcher, your turn.
Well, I'll honor the brevity, the pattern of brevity. I am deeply committed to the concept of free speech. It's not just a trite political aphorism. It is a core element of human nature. I can promise you one deliverable. You will be able to speak your mind openly. I will never engage in censorship.
Conclude your speech.
Okay, there should be 7 ballots, and we will give our ballots to our secretary, who will tally these ballots. And while that's being done, we will open up the voting then for vice chair. Nominations now open for vice chair.
Mr. Chairman,
Yes.
I would nominate Dr. Jameson, largely in the same spirit as that expressed by Duke. Public health has, in my opinion, suffered a blow to trust. It is manifestly true that the institutions of public health at the highest level have lied to us systematically for the last 3 years. If we are to reestablish trust, it is paramount that we tell the truth and that we are consistent in telling the truth, and that we never suppress the expression of the truth. I've come to know Jessica. I trust that she can fulfill that obligation.
All right, are there other nominations for vice chair?
I'm going to nominate Glenn Bailey,
All right,
if he wants to do it again.
Glenn Bailey has been nominated. Are there other nominations besides Dr. Jameson and Glenn Bailey? With Either. Are you having trouble with that chair? Let's take a moment and give you a chance to trade that off for one that you won't be nervous about the whole meeting.
Well, sir, it may be my BMI, but I'm happy to.
Tim,
I believe it's the chair.
Non-cooperating chair.
I would have laughed at that thing. We're in the midst of elections for a vice chair. Either of you wishing to make any kind of a speech?
No, I don't have a whole lot to say.
All right. If you have a card, we have two names. Sorry?
Glenn gave his away.
I need
Oh, you need, okay. Here, we're doing fine. Yeah, I think I did it. Again, if you want to take your ballots and fold them in half perhaps, and let's get them. Okay, before I open the nominations for the trustee position, Glenn, would you mind telling us a little bit of the responsibilities of that position? You are more familiar with that than anyone else.
Sure. The trustee and serves also on the executive council for the health districts. All 7 health districts have a trustee representing them and their interests, the issues that they think need to come before the executive committee. We talk about financial issues that the health services are facing. We talk about the different health issues that we're encountering, and if there's ways that we can adjust our operations to help deal with it more efficiently or better. We normally meet at least on a quarterly basis and discuss some of the issues. During the legislative session each year, frequently we'll meet every 2 weeks, depending on the issues that we see coming before the state legislature and what they're discussing, and whether we need to have a representation there. So those are some of the issues that we deal with on a regular basis. Each health district has the opportunity to conduct the annual conference, and it's usually their trustee that chairs the meeting that is held during that time frame, that annual conference. So, and I've enjoyed doing it. I've been able to learn a lot, and I think I've been fairly effective doing it. But that's pretty much what a trustee does.
Okay. Anyone else want to make a campaign speech?
Oh, that was a campaign speech.
Okay. Was there anyone else nominated? I don't recall.
No one was nominated.
No one's nominated.
Okay. Okay, we'll open up nominations then for the trustee position. Here again, anyone is eligible to be a trustee.
Mr. Chairman?
Yes.
Again, I really appreciate, the devotion that Glenn has had as well to that. Obviously, he enjoys that. But I also think that Tracy Cassidy would be a good candidate as well. So I'd like to entertain that.
Okay. Tracy Cassidy has been nominated. As any other nominations for a trustee position? If not, you have your ballot. Enter one of these names on your ballot, please.
I didn't. I don't know. Do you want to vote? I was gonna say, okay.
Keep in mind, if the question ever comes up
Okay.
about voting for yourself in this particular arena, keep in mind, if you choose not to vote, then all of a sudden you have denied your county a vote. So it's your responsibility to vote if you want to represent your county. Okay, I have the results here, tally, and for the chair, Thompson receives 3 votes, and Dr. Fletcher receives 4 votes and is elected. For the vice chair, Ben Bailey receives 2 votes, Dr. Jameson receives 5 votes, and Dr. Jameson is elected. For trustee, Ben Bailey receives 1 vote, and Tracy Cassidy receives 6 votes and is elected to trustee. Okay, so you have your elections, and this goes back to you. Okay. Now, this has nothing to do, and I'm on the spot, but I'm going to have to tell you right now, though it has nothing to do with this election. I have an emergency has arisen within my family, and I'm going to have to beg to be excused. Dr. Fletcher, you have been elected, and you may take over.
Well, sir, I would like to shake your hand.
Well, it'll take me a moment to stand.
You're an admirable human being. Thank you for all of your service.
You're welcome. Congratulations. Okay. Okay. Remember, this is just, I have been removed from the position, not from the board.
Don't forget, Marlo, your line is under the table then.
Oh, yes. I didn't get that. Ooh.
You can get your wife's
Yeah,
situation taken care of.
I hope so too. Okay.
Well, so as to not be disruptive, I would propose that we follow the agenda such as it is without making any other changes. So let's move to the fiscal report.
I think we need the executive
Oh.
council trustee report.
Oh, I'm sorry. I am so sorry. Go ahead.
The last trustee meeting was on the 4th of June, and it was telephonic. And we had all of the, all of the trustees were accounted for. The first item of concern was the Millennium Fund, which is $2.1 million. And that was proposed for approval, and that passed and was approved by the trustees and the executive committee. Next item on the agenda was the home visiting formula, and that issue was not approved. It was determined that the directors of the various health districts needed to revise that home visiting formula, which is $1 million. So that was postponed until that issue has been taken care of. That was the last item on the agenda. So we ended the meeting. So it's fairly brief. Those are the kind of meetings we like. Any questions? Okay,
Thank you.
that's all I had.
Okay, wonderful. Now fiscal report.
Thank you. Typically, for the July meeting, we present the June financial statements. However, due to issues with Luma, we'll be presenting the May financial statements. Beginning with cash history, we ended May with $6,024,000, an increase over the prior month of $135,000, and an increase of $579,000 over the prior year. Prior to adjusting for restricted funds and board committed funds, that left us 6.46 months in reserves. Once we adjust for board committed funds of $732,000 and program restricted funds of $2 million, that leaves us with 3.51 months in reserves. If there are no questions on the cash history, I'll move on to the budget to actual.
I have a question. How come this year there was an increase over last year of 500?
It would mainly be due to the opioid funds that we've received in fiscal year 24.
Okay.
So budget to actual is, we've presented on the March and April as well as February financial statements. We've had very little change over the last few months. Back in February, we reported that there was a $34,000 variance, unfavorable variance in environmental licenses and fees. And we need to remember that environmental is seasonal, so we can see that that variance has decreased. So it will be interesting to see what the June ending statement shows. Home health, that stayed the same. Of course, we all know that that closed in September of 23. Health services, negative variance of 190,000. General support services, these two items are related, these two line items. We have a variance, positive variance of 58,000, and that is mainly due to death certificates. I had budgeted for 30,000. We have approximately, when I looked, and I need to drill down a bit more on this, but we have approximately $50,000 in revenue in just processing death certificates. Grants and contracts, we have a variance, positive variance of 9,200. Interest, as I've previously presented, I under budgeted, so we have a positive variance of 134,000. Rent and other, we have negative variance of 9,200. Donations and miscellaneous, positive of 8,600. And let's see, what do we have here? Let's look at county. And this is a timing difference here as how the county quarterly appropriations are billed. Currently, it shows that we are 208,000 over, and we will see that that will narrow by the time June, we see the June statement. So total variance in revenue, we have 253,000 excess compared to what was budgeted. As previously discussed, we've been running under budget in personnel expenditures. We are under budget by 1,153,000. Operating expenses, we are under budget by 539,000. Capital expenditures, this is currently showing we are over budget by 47,000. Trustee benefits, under budget by 35,500. So total under budget in expenditures of 1,681,000. If we take our expenditures, our revenues less our expenditures, we have an excess of 1,100,000. So adjusting for our accruals and applying that to our beginning cash balance, it brings us back to the 6,024,000 that was reported as our ending cash balance as of May 31st. One thing that I do want to mention that you will see in the capital expenditures on the June statement is we received notification from Kootenai Health that through the manufacturer of our server and communication with Kootenai Health, that our server had reached its end of life and was due to be replaced. So we went ahead and pulled the trigger on that in this fiscal year, as opposed to budgeting for that in fiscal year 25. The primary reason why we did that was, one, it needed to be done. It was a security risk, and Kootenai Health could no longer support us if we did not replace it. But the other bonus to this is we have the infrastructure grant. The infrastructure grant in fiscal year 24 was currently underspent, and the $185,000 was approved by DHW to cover the cost of the server. So you will see that expenditure in the June financial statement. If there are no questions, yes?
The under budget on the total, if you can just go a little bit further, on the total personnel expenditures, is that because of positions that were open during that time period that haven't been filled, or?
We had a significant number of positions open through fiscal year 24.
Okay.
And fiscal year 24's budget compared to fiscal year 25 is down about, if I remember correctly, about 7 FTEs. The other component is I had budgeted for health insurance based on the amount that was published in the state's budget development manual, which is typical, but it came in at a lower rate. So health insurance was less than, the actual cost was less than what was actually budgeted. If there are no further questions, this is the end of my report.
Thank you.
Thank you.
Thank you, Mr. Chairman. Regards to the director's report, I have a few items. The first I have is on the future Board of Health meeting dates. It was brought to my attention from Dr. Jameson that she has a conflict with the fourth Thursday of the month that is outside of her control. So in order for her to continue participating in these meetings, I reached out to the various board members, and moving this to the third Thursday of the month seemed like an acceptable decision. So I had consulted with Marlo on that. The setting of the date per the bylaws is a discussion between the chair and the secretary.
In principle, that's fine with
Yes.
me. If I may add a comment, are we proposing again every other month?
I think that as the schedule is built, it would be, well, we didn't take into account the frequency of the meeting. It was just the remainder of the meetings through this
Right.
calendar year would be moved to
Then
the
if
third.
I may take this occasion, since we're talking about meeting times. And I'm just speaking for myself, and I'm actually going to look to the board to vote on this. I don't want to be the dictator here. But I find that when you have every other month, it acts sort of like summer vacation. You lose a certain momentum, and then you have to kind of go back and refresh yourself as what are we talking about again? So I would propose that we meet actually monthly, but in that spirit, we would have a 50-minute meeting, and it would be a hard stop, 1 hour. Hard stop. Mid-sentence, if I'm talking, Dr. Fletcher, time is up. It's something to think about. Now, as to what day of the week, I'm open. I'm a retired soul. Commissioner Cassidy, well, you're a commissioner. I mean, you guys, I would look to you to sort of run the program as to what works for you. You're still a working human being, Jessica. So I know, you work too. So I don't know. I'm the last one to vote on when to have it. I'll meet anytime. But give thought to actually having it every month, same time, and we have an abbreviated meeting. People's attention spans drift after a while. Those are my thoughts.
If I may add a comment to that, since this is kind of like late notice and everybody vacations in August, myself included, I don't know that we can make the transition next month, but I do think that it's a good idea, especially with what's been touted on the horizon, that there may be some significant advancements coming with pandemics, et cetera, that we may be needing to be more on top of what's coming, and just to be able to meet on a regular basis is fine. Just as one quick comment, I can meet any day of the week. Thursday is my worst day, but I can make it happen. So if there's a better day for everybody else, then I can adjust to that too. But if we need to keep it on Thursday, I'm good.
Tim, what are your thoughts?
I'll definitely be up on that screen more.
And that's fine, by the way.
I mean,
I think
just,
Zoom is perfectly respectful.
I mean, I'm looking at 3.5 hours of my day, just driving time.
Sure.
If
Yeah,
not
no, that's,
more.
yeah, that doesn't make sense.
And so, I mean, if it's important, then I can be here, but that's what I'll say.
Perfect.
Myself.
No, that's perfect.
I like the monthly idea, and I can definitely, once we figure out a schedule, I can make sure my days are scheduled. Clear that day.
Jessica?
I agree with the monthly idea. It's the later in the day, the better. Even if it's like we start at 1:30 or 2, or if it's only an hour, 2 to 3 kind of thing, I could make that work a lot easier than a 12, because I just have to take off the whole half of the day. It's,
Would you prefer morning?
no,
Oh, okay.
no. I start seeing patients at 6:30, so, I mean, we could do 5. What do you think? AM, I mean. No. I'm kidding.
Pass on that.
Exactly. Yeah, so, I mean.
Before or after cocktails?
I'm gonna plead the fifth on that one. Yeah, so I totally agree with that. Thursdays are, I can make it work as long as it's not the 4th Thursday. That's my operating room day.
I mean, I have no problem with having it start later than 12:30. I mean, I have no
That would be
problem with
wonderful.
2:00. I mean, that would be fine also.
Wonderful.
Yeah.
Later would be good.
June?
Yeah, actually, if we're restricting it to an hour, it's just great to have lunch and I can block off one patient or, 2 or something like that, rather than blocking off several hours. It'd be a lot
Glenn, I
better.
don't mean to be ignoring you, but you're also retired.
Actually, I've been a seasonal hired killer for the county, so.
Oh,
Well, assassins.
Weed control.
oh. So that kind of killer. Okay,
Oh, okay. I was
I'm
like,
glad you
oh,
clarified it, Glenn.
This just took a turn.
Edgy humor here.
Yeah, edgy.
Someone want to make a motion?
Do we agree on what date and time?
Day and time.
Mr. Chairman, if I may, it's not an action item, but certainly if there's a consensus, then you and I can meet and we can set those meeting times for future meetings.
Okay, I'm happy with that. We've gotten enough feedback here. I think we can make that work. Fair enough.
Anytime's fine with me.
Okay, thank you. Thank you, Aaron.
Next item that I have is regarding the consulting physician designation that's required by Idaho Statute 39409. This item, Dr. Fletcher and I had some discussion on, and I looked into the matter, and I'm just simply bringing this to the board for discussion on how we are currently satisfying that requirement. We have 2 agreements with Kootenai Health, essentially. One with the Kootenai Health residency program and a second one with Kootenai Health, which brings Dr. Anna Chase into the facility 2 times a month to provide both primary care as well as help facilitate the residency program. In regards to the health district's needs for a consulting physician, some happens in the primary care consulting, the day-to-day care of patients that we see. The other aspect is signing standing orders with regards to immunizations and different other processes that occur. Currently, in discussing this with Jenna, the consultation is happening largely with Dr. Chase, simply because she's in the facility, she knows our patients, she knows our resources, and so she's been frankly a very appropriate choice for making those decisions. Dr. McClandress, as part of Kootenai Health, has historically signed, I think it probably started when he was a board member, signing the standing orders, and that has continued to carry through. That practice can continue, or we can request that Dr. Chase sign that under the newer agreement that we have with Kootenai Health. But simply, I'm bringing this forward as a discussion item on how we're satisfying that requirement.
Thank you, Aaron. If I may make a few comments. The statute actually does make a recommendation that efforts be made by the participating county commissioners that at least one board member be a licensed physician. Implication being is you would like to have medical directorship in-house. Now, the language does not specify that it must be in-house, but the inference is if you're going to have an MD sitting on the board, take advantage of that individual. Well, in the wisdom of the 15 commissioners participating in Panhandle Health, you have 3. So you have a lot of homegrown talent. Now, in the 40 years I practiced medicine, oh, by the way, I don't want to be medical director. Let me just put that out right first. Now, in the 40 years I practiced medicine, I had occasion to work a number of times intimately with family practice programs that were involved both in clinical delivery of clinical medicine as well as educational. That is to say, they had residents and medical students. And the contract that PhD currently has is such a program. It's a robust, active family practice program, sees a bunch of patients, and they train residents. Their plate is full, and I'm not even going to comment on whether they've done an admirable job, not an admirable job. I will assume that they've been satisfactory. But they are not in a position to provide a lot of bandwidth, a lot of attention to Panhandle Health. And I say this not from direct knowledge of that group, but from, again, 40 years of experience interfacing with the type of program where you're teaching residents and you're seeing a bunch of patients. Oh, and by the way, we're the medical director of the local public health district. So I would strongly argue that we take advantage of the in-house talent, licensed physicians, and essentially reassign the medical directorship to one of your three existing physicians. That being said, I've already indicated to you I'm not interested. And not only that, I let my license lapse, so actually technically I wouldn't even be legal. And that leaves two other souls, and I've actually caucused with both souls. And Dr. Johnson has actually expressed an interest. He is actively interested in being a medical director. Now, it also happens, and he brought this to my attention recently, in his prior history, and maybe I should make a comment and then I'm going to let you comment further, is it happens in a previous life form. He actually was in charge of a pandemic program for very large billion-dollar corporations. So he comes to the table with a specific expertise, something I don't have as a vascular radiologist. I mean, you get so subspecialized in medicine, but Duke, you want to take over from here?
Well, yeah, I got involved in preventive medicine over 30 years ago, and became medical director of the largest supplement manufacturer in the world, and so multi-billion-dollar company. And so we started doing assessments on people from around the world, both customers and distributors for that company. And they built a center of optimal health, and we ran 17,000 people from around the world. So through our program, and I did personal assessments on 90% of those people. In order to do so, I really had to understand the health, major risk factors, health conditions, how their government affected their health care, their diet, lifestyle, major causes of death, worked with the Ministry of Health of many of those companies, because when you represent a multi-billion-dollar company, you need to know your stuff, especially at that high level. And as it ended up, they said, well, we can't send everyone through to the center in California. Can you come to our country? And so I ended up teaching preventive medicine in 30 different countries around the world, standing on stage in front of thousands of people, many of them healthcare professionals. So I really had to know it at a real deep level. And in that capacity, there were, I think, if I remember correctly, 3 pandemics that occurred during my 14 years there. And one of them was SARS-1 and COVID is SARS-2. And so I was very familiar with coronaviruses and SARS virus back in 2003. And as medical director of that company, I was being requested, is it safe for people to travel from Japan or, to Italy, for example, during the pandemic, et cetera. And so that occurred in 3 different pandemics. And so I've just taken a natural interest in the epidemiology of pandemics per se. And So when SARS-2 broke out, it was not a shock to me. And I was comparing SARS-2 with SARS-1, and boy, we're doing things differently, et cetera, et cetera. So it's really interesting. I didn't know the statutes per se, Eric, as far as exact requirements, but my interest would be more on that global level rather than in the clinic level, because I'm like really busy right now, and I can't add the clinic portion to it per se, but to maybe and I think we can help define what it is we want, because I think there's a vagueness to, from my understanding, as to what that medical director responsibilities are. But I think that, as I mentioned earlier, in retrospect, now it's coming out that, well, we have to admit at CDC, we really didn't have the science behind why it was 6 foot distancing between people, because there wasn't any science to support that whatsoever. And it's like, why 6 and not 5, not 9, not 18? I mean, where'd you come up with that number? And you can't find that anywhere. And I knew that at the time, and now they're admitting it. And so there were a lot of things that came down. It's like, I think we can best serve the people of North Idaho if we just do everything based on really solid science and not like what's coming out just random. And so I'd be very interested in, because there were obviously negative impacts from what occurred with all of the restrictions. And so I think that if we had a little bit more local control, I think we know more about the health of people of North Idaho than someone from Washington, D.C. or Georgia. And I think that we could better serve the people and better serve the community. So I'm more interested in that than the clinic or standing orders or et cetera, but maybe still to some degree have some input, but not necessarily, certainly not from the resident standpoint.
So I'm sensitive to what you've said there. There are different aspects to this medical directorship.
Mm-hmm.
One of them would be, if you will, the true direction.
Mm-hmm.
In other words, setting policy, doing a thorough, and shall we say, review of what clinical services are offered, how those services are executed, some of the detail of programmatic details.
Mm-hmm.
The other aspect, and you've alluded to it accurately, and that is the hands-on, the person who actually has a stethoscope and is seeing patients. I'm open to any suggestion you want. For instance, I would take feedback from our clinical directors and have an understanding. Does this physician who comes in once every 2 weeks, is this working? Is this acceptable to you? If it is, my proposal would be to leave that alone. And then only change, if you will, the higher level direction. Ultimately, though, it's your call. If you're appointed medical director, I'm not going to micromanage you. You would, in the long run, figure out what's in the best interest of the citizenry of Idaho. Am I clear on what I've said?
And
Eric?
Mr. Chairman, if I can maybe make a point of distinction, the statute, as has been mentioned, is not crystal clear, but the terminology used is not medical director, it's consulting physician, and we can certainly discuss, what responsibilities that may entail, because it's not clearly identified in statute. But one point that I would make in regards to Dr. Chase is, because she's in our facility and her expertise lies in primary care and OBGYN, which is at the core of the work that we do, that a lot of the operational aspects of what we do focus on her medical expertise. Certainly in the scheme of a pandemic or a larger community issue, this board and the expertise of the doctors that we have, that's incredibly valuable moving forward. But from a day-to-day operation, I'd prefer not to see any radical changes to what we're currently doing. Certainly we can, and I'd welcome Jen's input
please.
on.
Yeah.
Weigh in,
Mr.
please.
Chairman, absolutely. So Dr. Chase, that's an agreement we've had in place with her, I believe, 1.5 years. She's been coming to our clinics typically twice a month.
So she brings a resident from the Kootenai Health Residency Program into the clinics. They see patients. So she's entrenched. She's a provider here in our clinic. She's an outstanding provider, and we're very grateful to have her. She does nurse practitioner consults as well. So she's available here on site. Our 3 nurse practitioners consult with her on complex patients. If they have something that's a little, new, different, just want some guidance from a physician, that's who they rely on for that. We have worked with her on creation of several procedures, including a controlled substance procedure that PhD did not typically have in place. Largely, our nurse practitioners weren't really comfortable prescribing controlled substances, so we worked with Dr. Chase and established an entire procedure around that, contracts with patients, details on how we refill medications. I mean, right down to the nuts and bolts of it. And she's been absolutely phenomenal. We're revising STD presentations that we have given throughout the health district for years and years and years. Have been really kind of cleaning those up, adding modern data into those. She's reviewed those from a physician standpoint. So I think from my perspective on a day-to-day operation, just having her in our clinics, we also have a PhD nurse practitioner who is the clinic manager. So largely very capable individual managing the clinic as well, but with the oversight of Dr. Chase, I think it's been a wonderful partnership. I wouldn't change that. And I would add, I think largely our group, Eric and I, Kim, we weren't division administrators largely during the pandemic, but my understanding is should something come down the hatch to what you're referring to, I believe my understanding is largely those decisions are Board of Health decisions. So those are not coming from like a director of clinical services. That would be coming from our group here in this room deciding where the board, how we plan to respond to that.
Right. I'm a strong believer, if it's not broken, don't fix it. So I wouldn't want to touch any of that. I'm just thinking more like I was saying originally, more from a global point of view, that I think a lot of times that there was so much fear with the original, what came out with COVID, nobody knew what to expect. And so everybody just kind of, backed down and just said, okay, well, let's take the safe position. But it would just be, I think, beneficial for everybody if there could be someone just looking at the global aspects, so that when those things come down, I feel real confident at that level. I wouldn't want to touch what's going on in the clinic. If that's working really, really well, that's awesome. Yeah, I wouldn't want to touch that. I wasn't even thinking in that realm as much as more like, well, because as Dr. Fletcher had mentioned earlier, the rumor in the community among people who don't attend here was that some people felt uncomfortable, but if there was a voice who said, well, this is based on this is based on this, and we're making the decision not because of these people, but because of the science that we can document, show you, give you a verification of, I think that trust is huge, that there would be a greater inflow of people here if they could feel like, wow, I can go over there and I'll be safe, I'll be taken care of, it'll be for my best interest. And that's my goal, is just more at that global level.
So Eric, how do you want to proceed?
Mr. Chair, I would say that it's a continued discussion. As has been stated, pandemics are coming, and those discussions will occur with the board on the best role of the Panhandle Health District in the future. From an operational, day-to-day operational standpoint, we will be bringing that information to the board, as Marlo had indicated, and trying to let the board know what our issues are in each of our programs, and seeking input on solutions and how we can better improve services.
But we've got 2 contracts.
Correct.
We have the overriding medical director supervision, and then we have the Dr. Chase, who is contracted to deliver certain services within parameters.
Yeah, and Mr. Chair, maybe what's appropriate is to take those 2 and meld them together, since they're both with Kootenai Health, so that we're continuing our residency program with Kootenai Health, and we're continuing our relationship with Dr. Chase in the clinic, and see if we can't have a combination of her completing the standing orders as well as consulting with us on those daily client cases.
And how do you imagine Dr. Johnson fitting into this scenario?
Well, certainly he's, as any board member, is welcome to review the current processes that we or protocols that we have in place, and we can
But
discuss.
only as a board member, doesn't have a specific designation or responsibility.
I'm not saying that that's necessary at this time.
Well, one thing that may be important is definition of terms, a lot of times, because the term medical director, if still that kind of by definition, by most people would say, well, I'm the final say, I'm the director per se. And the board, I guess, can vote or not vote on whether or not we agree with that director's position. But I'm not sure that someone who oversees the clinic per se has to also be the one that answers at a global level. For what's recommended by the health district for pandemics, et cetera. So, I think there could be a differentiation of the two positions.
Absolutely, Chairman. I do not believe that we would be going to Dr. Chase for questions on pandemic response. Those discussions would absolutely be coming to the board for.
Nor would we go to the family health clinic for, shall we say, higher level programmatic issues.
Correct.
Okay, so is there value in designating a specific personality on the board who would assume that responsibility, a go-to person, not just any board member?
Mr. Chair, I think what the most appropriate step may be is to define what responsibilities we're exactly talking about, because there is a distinction here, but I don't know if we're going to be able to flesh it out in this
And
particular.
that's very fair, what you've said.
Yeah,
I like what you just said.
Exactly, because when
Yeah.
emergencies happen, lots of people want to take control. I know that's from being in a lot of traumatic, situations, right? And so, but if there's a definition of, okay, who's leading this?
Right.
Okay, there's clarity and consistency, and everybody feels better about, okay, there's no confusion, this is what we do. And somebody takes the heat for it, good or bad, I don't think that's all. Yeah, I think that definition is key.
And Mr. Chair, maybe that's something we clarify in the bylaws as far as the role of a specific, of a physician on the board.
May also be something, if I may take this opportunity to speak kind of out of turn. Eric and I spoke of the possibility of the personalities in this room right now and others holding a strategic planning meeting. I think it's time that we sort of have set aside a moment with an appropriate venue. I guess everyone here has participated in these sort of strategic planning. And one of the topics would be to drill down on what is a medical director, the roles and responsibilities of a medical director. Do we want a medical director along the lines of what you're talking about? And then that would parlay into bylaws. Are you comfortable with that?
Yes.
Do?
Mhm, yeah.
Okay. Does anyone want to weigh in on that?
I would add it, and I'm just trying to catch up with where you're at.
Okay.
That from the global perspective, it almost sounds like this is sort of somebody who would incident command, so to speak, like when something happens. So you would kind of be involved. What you're suggesting would be involved from a preparedness standpoint, involving clinical personnel should something happened and we have an incident underway. Is that kind of what you're thinking? Like the medical director would be part of that?
More so, because I've gone through many of those incident command trainings with FEMA, et cetera, and his role is, I was interested in that, his role as coroner, because, they were mentioning, it's like, okay, I need to take all, I've taken almost all of the incident commands, but I think that having a plan in place just reduces it, and someone that's at the clinic level isn't necessarily thinking incident command. See, that's more of where my
Right, that's
thinking's
kind of end of line,
Yep.
okay, clinic, moving forward, we're gonna have, Mpox vaccine or just,
Exactly,
yes, that is
exactly.
logistics, boots on the ground. You're kind of looking at, here's coming
Absolutely.
a situation, and then starting to put heads together and
Right.
trickle that down
And
into.
how do we think of it rather than, okay, because I know in the ER, sometimes I'd be overwhelmed because bodies are hitting the ER and it's just like we're overwhelmed. But if there's somebody that says, okay, no, we have to divert these people over here, sorry, and we have to, you have to come back later, et cetera, et cetera. Sometimes just having those things in place can save everybody and save a lot of abuse and make things work a lot more smoothly. And that's more of what I'm thinking. Not the day-to-day
Yeah.
stuff, no.
I'm just trying to catch up so I understand
No,
what.
Probably didn't describe it very well.
No, it's okay.
Well, your articulation is actually on point. It's
You bet.
perfect.
You bet.
I was a medical director for 10 years. And the last thing I wanted to do was get involved in everyone's stuff. But on occasion, issues would arise. There were unhappy people. There were bad outcomes. There was something that hit the radar screen, generally if they involved lawyers. And then the medical director sort of has to get involved. And we worked out policies and procedures. I mean, there's a lot of background work that needs to occur. But it's definitely not a hands-on role day to day. It is more a larger program. That's in keeping with what I think you just said. I'm in total agreement with you. And I think Duke is too.
Absolutely. In fact, you can't be global if you're hands-on.
Right.
I mean, it's like you have to keep your hands on, right? And see it impartially. Yeah.
Okay, so we're not going to meet next month anyway. Is that right, Aaron?
That's correct.
Because there was some misgivings about it. But have on your radar screen for then the September meeting, this will come up. We can either enjoy, Eric and I will hash it out, and Duke. And maybe we'll come back to you with a specific set of suggestions, action item, and I will reach out to all of the board members, by the way. Do you want this to be, and directors, do you want it to be something that we hash out collectively in a strategic planning meeting? I don't know. I don't have a huge amount of ownership of either approach. I would like by the end of the year that we figured this out. That's my only request. Mary?
You're saying the calendar year, not the fiscal year.
Oh, I don't know. I was thinking calendar year, Christmas.
Okay.
I mean, my gut reaction is I think we kind of vaguely hashed it out now. And so it kind of takes, I don't think a separate meeting is needed, just kind of like some guidelines to say, do you agree with this? Should we eliminate this? Or if these 5 things, this is good, this is bad. I think we could come pretty close to the definition, at the next board meeting by just making modifications thereof and during the board meeting, then voting on it.
So noted. Is everyone in agreement with what he just said?
Yeah, I think you guys can do that pretty, yeah.
Okay, so noted. It'll happen.
Moving on, the next item I have is Mark Lyons, who has been our long-standing legal counsel, is downsizing his practice as he's moving into retirement. We will need to be replacing our legal counsel here in the foreseeable future. He has provided a recommendation of a Nathan Oler with Lake City Law Group. I am scheduled to meet, actually, I've asked Christine as our representative from risk management to sit in on that meeting just to meet with him and get an idea of his thoughts. But there will likely be other individuals that we will consider for the role. Just wanted to bring that to the attention of the board.
I like the idea of several people, just, and several resumes just to be able to make a choice. I like that idea.
Okay.
Yeah.
I would also like the input from all board members.
Will do.
It's kind of in keeping with what Duke was saying. Let's entertain more than one law firm.
Mhm.
And then I am actively asking for all of you to get to know these people, get a feel for them, Yeah, I think legal counsel is vitally important.
Mhm.
And in that spirit, I can already tell you what will be on my radar screen. If the legal counsel, in reading the bylaws and the statutes, comes to the conclusion that board members are to have only a passive role, as has been the experience with our existing legal counsel, then that person will not be hired. As we move forward, I'm looking for active participation of you guys. I want to hear from you.
The final item I have is Marlo had asked that I provide an update of changes to district directors throughout the state. There have been, of the 7 health districts, there have been 4 recent changes or one upcoming change. Obviously, I'm a newer director with the health districts. District 2 recently made a change. Kayla Springer replaced Carol Morley, who had been a longstanding director there. 3 and 4 continue to retain their existing directors. Melody Bauer, who's with District 5, has announced her retirement coming in August, so she will be replaced. District 6 keeps Maggie Mann as a director, and James Corbett has been the district director in District 7 for about 2 to 3 years. And that is all I have.
Well, thank you. All right, does anyone have any other comments to make, or questions, or?
I think it's been a good discussion, and I think it's a good direction to go.
Hearing no further matters, and I take a motion to adjourn. Second?
Seconded.
All right. Barring no objection, meeting will close. Thank you. Thank you, everyone, for showing up, particularly those that had to drive an hour and a half. And you were